the most charismatic speaker we have. He's president of Foxy in 2011, Foxy representative to Suffolk, Vidya Vibhushan Award by Foxy and ICOG in 2020, founder of Parchi Institute for Mother and Child Care, managing chairman of People Like Me Who Wants to Retire. You are stimulating, sir. Teaching is his passion, to be a man rather than a great man, but we all know he's a great man forever. Thank you, sir.
Revered chairpersons, star speakers of this particular great scientific day, Apurva, Rajiv, Ashish, and Shahrukh Khan, Jatin, and the interested fellows for this educational program and the team of 49 led by Jyoti, ladies and few men, I don't know whether they are gentlemen or not. Well, I bring greetings from the place of Lord Jagannath, and this is a place where I was born as a President Foxy way back in 2011. So I felt that it's a homecoming every time when I come to Hyderabad. And there are very, very common topics and complex topics in obstetrics and gynecology where this is true. If you are not able to convince, at least confuse. I'm not standing here to confuse you people, but over the years of my experience and treating such cases, I'll just convey messages, what is true and what is not true. Recent advances in recurrent pregnancy loss, RPL, has become really a challenge to the clinicians and a tragedy to the couple. And till today, a lot of researchers, conceptual advances, technological advances has been there, but still we are dilemma where to find the cause and treatment particularly. But this is true, that every pregnancy is wanted and every pregnancy is valuable. When we were students, there was a topic called valuable pregnancy. I was asking my teachers, is there some pregnancy not valuable? Now we think every pregnancy is valuable and every pregnancy is wanted. If this philosophy is there with the clinicians as well as with the researchers, I think they must think that loss of one pregnancy is a loss of life from the universe. That things will change and we'll get a good perinatal outcome for that. This is the fallacies of human reproduction. You're all fertility specialists present over here. Human reproduction basically is a negative phenomenon in comparison, in contrast to the veterinary, where it believes in multiples. This is scientific data which clearly shows that 100 exposed ova, out of which 84 become zygotes and 60 go to the infertility specialist from the beginning. From 84 zygotes, 69 implant and produce HCG, and 15 fail to implant, failure of implantation, which is really a point of ponder research on the fertility specialist and all that. Out of that, 27 about promptly before the next menses. These are biochemical pregnancy, but no clinical evidence of pregnancy. Beta ICG is positive. And 42 persist as a clinical pregnancy, out of which 15 are lost in form of a clinical abortions, malformation, other pregnancy loss, and 27 are the survivors. So today, after realizing this scientific data, all of us should pray the Supreme Creator that all of us are 27 out of 100. So therefore, human reproduction is absolutely a negative phenomenon, there is no doubt about it. Now researchers and clinicians point at certain levels how to reduce this 42% clinical abortion of 15%, how to reduce that. Then the biochemical pregnancy, not clinical pregnancy, what are the factors involved in the embryo decidual talk where there is a defective and how to improve that. And lastly, the improvement of implantation. These are the three areas of concern before the clinicians as well as the researchers for that. So I will be telling about the clinician's perspective, not telling about some data, feedback, all the evidences, literatures and all that. I will not go for that. Basically, I'm a clinician and I want a clinician's perspective. When we come to the pregnancy loss, we divide into biochemical versus preclinical loss and a clinical loss. Clinical pregnancies are again divided into pre-embryonic, embryonic and fetal. And in trimester wise also we divide into first trimester, second trimester and late fetal loss. The division of these points to some common cause, because that some causes which is there affecting the pre-embryonic is not related to the fetal loss. And some cases where there is a first trimester loss, the causes are completely different than the late fetal loss. So this is the main point for which we could point out that which is the cause in that particular age group. I am not deliberately omitting these two rare conditions, pregnancy on abnormal location, ectopic pregnancy, and pregnancy of unknown location now has become more common when biochemistry, the immunological by beta-ICG, as well as the high-resolution sonography has demonstrated that neither in the uterus nor outside the uterus, somewhere in the body, we will evaluate the case of pregnancy of unknown location for that. That's not my area of concern today. Now, as far as the clinicians, patients ask two relevant questions for that. Doctor, why this has happened? With one pregnancy loss also they ask, why this has happened? And you say that there are many causes, out of which the genetic and all that, some defective embryo, defective germplasm is responsible for that. And if you go for a statistics, 15% of the pregnancy are lost, first pregnancy is lost, sporadic pregnancy, which we don't bother about it. So she is convinced. The second important question that, what will happen in the next pregnancy? Am I a baba or mama so that I will say tathastu, next pregnancy will be all right? That's $1 million question now in this era when conceptual advances in reproductive endocrinology, immunology, genetics and molecular biology, innovations of newer drugs and newer techniques, technological advances. Now this is a point of introspection where we stand now. It draws more controversies than consensus, more of guesswork and more of empirical treatment for that. Now the clinician's approach, first important is an evaluation definitive treatment. When you find a pregnancy loss and more so a recurrent pregnancy loss, you have to identify, find out what is the cause. But more important and equally important is the psychological aspects and counseling. Because these are the patients now we are seeing. Even with one pregnancy loss, the couple is really depressed and they are very much worried about it with one pregnancy loss also. Because of the advanced age, the marriage, the career-seeking girl, and very access to the net and Googles and all that. They consult various people and become confused about it. So this is important as a clinicians. We must find out the cause and at the same time psychological aspects and counseling should be there for that. Because this is in 50% of the cases we could know the cause. In rest 50% of the cases we do not know the cause. Where out of it 70 to 80% will have a favorable course where they start, Pedersen has given a concept of tender loving care for that. What is a tender loving care? I could understand what is a tender, I could understand what is a loving, I could understand what is a care. But what is a TLC? It's nothing but an empathy, it's nothing but a psychological support and a counseling for that also. That's also have an immense value for that also. I can imagine, I can point one instance of mine, one patient came to me, 7 pregnancy loss, she was completely depressed, attempting suicide twice, rescued, absolutely depressed, psychic. They came, they have a total, I think, hatredness for the doctors. They sat beside me. She didn't like to talk to me. I thought she is repulsive of the doctors for that. And all investigations have been done, everything is normal for that. That's a case where the no cause has been found, but lost 7 pregnancies. How to deal, how to make an approach? I was confused about it. If I ask something, she will react. So without asking something, I found a locket of Lord Krishna there in the neck. Then I asked one question. Do you know Lord Krishna was being delivered in which pregnancy? She suddenly became cheered up. In 8th pregnancy. Now she has lost 7 pregnancy loss. She is really cheered up when I pointed this question for that. So I told, maybe that I do not know what is the cause, what will be the future. But at least don't commit suicide. Try once. Maybe that the Lord Krishna must be wanting to come in your uterus this time. And therefore try this time. And then you commit suicide. Don't come to me. Do you think, are you sure that Lord Krishna will come to in my body and my uterus? I told maybe. So I created a confidence in the body and mind of that particular patient by these single words for that. And fortunately, by the grace of God, and by coincidence also, she conceived within 2 months, absolutely normal progress during whole of the pregnancy. And of course, I didn't allow for vaginal delivery, I did a cesarean section. And a male baby was being delivered, and he gave name of the baby Jagannath for that also. So this is one example of what is called a tender loving care. Without anything, we are always targeting for the treatment part and forgetting about the emotional aspect and the connect with the people and the human part of. Human part is also more important for that. So create confidence in the body and mind of the patient, you will be successful for that. Now confirmation of the pregnancy is another important part for that. Many patients tell that I have lost 2 to 3 pregnancy. How could you know? A period of amenorrhea followed by bleeding for 2 months? Is it a pregnancy? It could be a metropathic cycle, an anovulatory cycle for that also. So first a confirmation of the pregnancy should be there. You see for the reports of previous reports of whether biochemical test, HCG is positive or even UPT positive, sonographic evidence of pregnancy or some histopathological evidence of product of conception. Then only you can say that it's a pregnancy. Then there is a isolated versus recurrent. There is a different cause for that also, because one common cause is responsible for the recurrent pregnancy. Duration of pregnancy, I have already elaborated that. Type of pregnancy. From the history you can know the pregnancy, because nowadays with the era of technological gadgets, we are away from the touch to tech. So touch and clinical sense is also required gone are the days. So take history. And a classical example is the mid-trimester spontaneous loss and pointing towards cervical insufficiency. So this can be done for that. Sonographic scanning. I'm not a madman talking about sonographic and scanning. Just to impress what is that. See the reports of the sonography and previous reports. And there is a difference of radiologists doing a sonography and an obstetrician, you people doing a sonography, there is a lot of difference for that. Radiologists give a sonography impression, is that clinical, the sonographic evidence of missed abortion. Below it, there are prominent 2 sentences, not for medical legal purpose, and second to be clinically correlated. See, this is the report I am seeing with all my reports in radiological clinic. But an obstetrician or you people doing a sonography, you should know whether the gestational sac is there or not, whether the gestational sac is normal or not, whether the gestational sac contains the embryonic pole or not, whether the embryonic pole contains cardiac activity or not. So these all are important. Even presence of yolk sac is there or not. If this is there, difference. If a gestational sac doesn't contain an embryonic pole or a fetal node, it is completely an embryonic pregnancy and mainly attributable to some genetic cause for that. Suppose the cardiac activity is there and then subsequently it has disappeared after 2 weeks. Certainly some of the factors responsible for that, either in the molecular level or in the vascular level or in the immunological level, which is acting on that and target for that. So this is the important for that. Modality of intervention is different. Any investigation, they come with a lot of investigations. Don't repeat the same investigation unless your spouse is a biochemist or a pathologist. Now the definition is a controversy and a consensus. The pitfalls in diagnosis, we have a simplified clinical approach, prediction and prevention. Definitely, we want more of definitive treatment than empirical therapy. Psychosocial issues I have already told for that. Now, the definition, there was a lot of controversy because now it has been solved, whether 2 or 3. Now 2 or 3, the 3 become ASRM of the world, S3 as the world biggest global organizations of human reproduction. And from the beginning, ASRM says that yes, 2 pregnancy loss, we call it as recurrent pregnancy loss, and S3 still reserves an old, is a 3 pregnancy loss. Now the current task force group of RPL in S3 also agreed with that the 2, and there is no controversy. 2, we call it as a pregnancy, recurrent pregnancy loss. But my point is that whether with 1 pregnancy loss, whether we investigate or not, because now with the changing demography, with elderly women going for a pregnancy at the age of 35, 36, with 1 pregnancy loss, then you say that no, don't investigate. You come and fulfill the criteria of definition of recurrent pregnancy, then I will investigate. That's not important for that. So do some investigations, preferably non-invasive investigations, even with 1 pregnancy loss for that. Now identifiable factors, these are all genetic, immunologic, anatomic, infective and endocrine are they belonging to the 50% factors, and rest 50% we are very satisfied with the use of what is called idiopathic. Idiopathic, I believe that idiopathic should be obsolete from medical dictionary and should be replaced by what is called a cryptogenic. Our booster antenna is not able to capture those, and that's why we call it as idiopathic. My definition of idiopathic is when the doctor is an idiot and patient's condition become pathetic, it is idiopathic for that also. So these are some gray zones, very early pregnancy loss, embryo or the endometrium, the talk between that, implantation failure, ART pregnancies, recurrent malformations, recurrent molar pregnancies, PCOS, declining ovarian function. Even you see the diminished ovarian reserve, you get a pregnancy, but ultimately the quality of the ovum is such that it becomes a miscarriage for that. This is one of the cause. A defective quality of the embryo is important, particularly in the case of declining ovarian function as well as in a PCOS. Male factor abnormality, I think DFA, the fragmentation, DNA fragmentation, some people attribute for that also, but I have done a study of this. I didn't find a correlation between DFI and all that. Stress and pregnancy waste is different. And there are some women, they are destined to lose babies and they are deprived of motherhood for that. I say these are unlucky mother. They have a mixed pattern of loss. I have seen many patients, they have experienced everything. Whatever written in the fetal medicine, they have got it. First trimester loss, second trimester loss, congenital malformation, then secondary infertility, then IUD, late in the labor and all that. This I called an unlucky mother. So in obstetric result, end result, I say 4 combinations and permutations. Lucky mother and lucky obstetrician, excellent prognosis. Unlucky mother and unlucky obstetrician, worst prognosis. Lucky mother and unlucky obstetrician, unlucky mother and lucky obstetrician, mixed prognosis for that also. I imagine where some of my patients who have lost 4, 5 pregnancy and all that, all types of, these type of cases, the patient don't leave me and I say that yes. Then I write, what next? I give a prescription. And she moved to one pharmacy to another and she find, sir, the medicines we have written has not been followed up and nobody understands this medicine for that. Then they came, what is the medicine I have written? Change the doctor. So this is the prescription I give it, change the doctor. Maybe that your star may be very conversant with the other star so that you may get a result for that also. Genetic. When my teachers were teaching genetic, the immunology and endocrinology, this is a very good hypnotic and sedative dose. I don't want to repeat this for that. But remember, there is a lot of battle and lot of debate between the parental karyotyping versus abortus karyotyping. And just for the clinicians, remember in the parental karyotyping, one thing you notice, whether it's a balanced translocation. When you find a balanced translocation, you can be a baba and mama. You can say that yes, next time you will have to abort for that also. And there you send it to Jyoti for some gamete transport, this side, that side and all that. Immunologic, APLA has a strong correlation. Initially, APLA was considered as one of the synonymous with RPL, but now this spectrum is increased to recurrent pregnancy loss, from recurrent pregnancy loss to early onset pre-eclampsia and eclampsia. And eclampsia, remote from term, is a distinct entity related to APLA. IUGR, IUFD, particularly in second and early third trimester, these are APLA particularly for that. And there is evidence-based and there is a treatment, new hope for that. So these LA, ACL and beta-2 glycoprotein there are 2 methods in which you diagnose APLA. One is a clinical criteria, another a laboratory criteria. You do an APLA test and get a positivity result for that. But there is absolutely very variable for that. It's not at all dependable. The clinical is more dependable criteria of that. One or more unexplained death of a morphologically normal fetus at or beyond 10th week of gestation with normal fetal morphology documented by ultrasound or by direct examination of the fetus, or one or more premature births of a morphologically normal neonate at or before 34th week of gestation because of severe preeclampsia and eclampsia or severe placental insufficiency, or 3 or more unexplained consecutive spontaneous abortions before the 10th week of gestation with maternal anatomical and hormonal abnormalities and paternal and maternal chromosomal causes. Any one it is found, think that is APLA syndrome and start treatment with that. There is a revolutionary treatment for that because APLA test is reliability is very question mark for that because widespread interlaboratory variables, 2 tests are required and all these confusions about these tests for that. And these treatment traditionally we are giving prednisolone and aspirin, now heparin or low molecular weight of heparin with aspirin is the rewarding results for that. So both are same, effectivity both are same, both have a benefit and risks also. Heparin when we give, the only benefit is the low cost. But heparin when we give, in 3 doses you have to give it and repeated monitoring is required for that. Repeated periodical PTA, PTT monitoring is required for that also. These are the main demerits. But low molecular weight heparin once a day, 24 hours and the cost is little more, no monitoring is required for that. I remember Santa is here. Santa was the chairperson of the Food and Drug Committee when I was the president of FOXY. And I gave all 27 chairpersons my cabinet ministers. I brought the funds from the different company. One company, you do 25, 50, 100 CMEs on that particular aspect, all over. Santa told, sir, I'm a food and drugs committee. What topic I will make it for that? I remember this is one, at that time, the low molecular heparin was very new concept for that. I told that you do this and take a company with that and pharmaceutical. Did more than 50 CMEs across the country, and the name I have designed, low weight and high impact designer molecule, this LMWH. And Santa is the main person. He done a lot of CMEs on this particular thing on RPL. And the companies were also very happy that we could be able to bring the molecule from angina to vagina. From that was used by cardiologists for a very short period for 5-7 days. Now they are used for 8 months. So they are very happy, and this has a rewarding results also. We do not promote the company as such, but these are rewarding results for that. And because you see, heparin aspirin versus heparin, 54% increase in live birth rate for that. Increased live birth rate, when to start, how long, what doses. Earlier the recommendation was that as soon as the fetal heart is demonstrated by sonography, you add heparin or low molecular weight. Now there is a change. Even we learn from the infertility specialist, right from the embryo transfer, they are giving some cases with implantation failure. We start little earlier, even before the appearance of the fetal heart rate for that also. Now, anatomic factors, the uterine factors. These are some of the uterine factors. You can see a big submucous myoma, a grade, I think a grade 0, grade 1, or even grade 2, FIGO. I think these are the causes for the recurrent pregnancy loss, and identify these. And hysteroscopic surgery is one of the prominent thing where you can do it. And now it is done by bipolar, not by unipolar with the glycine toxicity and all that. Either with a single sitting or with a double sitting. Now this is again a case where we find this Mullerian anomaly. Mullerian anomaly earlier was being diagnosed by hysteroscopy. Now it can be diagnosed by 3D sonography for that on MRI. So these are very, very rewarding results. The only thing is that it's a 5 minutes procedure for hysteroscopy resection of the septum, and you can get a very good result for that. There are still controversies whether it is recommended for arcuate uterus or not. What is the muscle which is remaining above, whether by doing a MRI or 3D scan for that. But this is absolutely rewarding for that. Now this is another case where synechia, incomplete synechia, cause of recurrent pregnancy loss. Complete synechia, cause of infertility for that. So these are all very rewarding surgery for the hysteroscopic aspect for that. Cervical insufficiency. When we were reading, we were discussing about cervical incompetence. Now it is replaced as cervical insufficiency. The structure and function are both important for that also. So magnitude of the problem is overestimated, nature of pregnancy loss, diagnostic modalities, and the treatment options for that. This is one of the example where the treatment is during the time of pregnancy, and suture, the cervical encerclase is the rewarding surgery for that in a case of cervical insufficiency. Of course, there are more lot of literature combining with the progesterone versus this cerclase for that. But cerclase, where you put it, when you put it, how you put it, and what materials there is a lot of deviation for that. Where you put it, I think the levels, 3 levels. Initially, it is at the level of the internal os. At the level of the internal os was the first. Then the McDonald came below the level of the internal os, which is becoming easier. And if it fails, high cervicoisthmic cerclase nowadays by the endoscopic procedures, by the laparoscopic procedures. So the different materials are used, starting from the silk to the proline to the seed, other very sophisticated seed or sutures which is there used for that, like Marcelin tap. Now, this is a McDonald, very simple. We are using a Admika doctor. I never use this Marcelin's, I think, tap, which is very costly for that. I use this number 4. Suture India is manufacturing cervical suture, and number 4 with a round body needle, 30 mm, and just retract the anterior with the speculum, retract the intravaginal wall, and that you can get a length of about 3.5 to 4 centimeter for that. And it's very easy procedure, the McDonald's and cerclase. Now, as an endoscopic surgeon also, I tried where they failed. All the sutures, the earlier sutures they have given, they're still not working in that, or she has underwent some Fodder's repair or amputation where a high suture is required. This is cervicoisthmic suture by laparoscopy.
By laparoscopy, there is a defect in that. The puncturing in the wrong place will have torrential bleeding for that, and it's technically little difficult. More important is that in case there is an IUD, in case there is a congenital malformation, in case there is a leaking, how can you remove the suture? You have to again do a laparoscopy or laparotomy or a colpotomy to remove the suture for that. So I found as a vaginal surgeon why this cannot be replicated by vaginal route for that. So vaginal route, if it can be given, anteriorly I dissected it, posteriorly opened the pouch of Douglas, and then put the suture in the cervix in the posterior fornix in the vagina, and then the same thing at a higher level, it goes medial to the vessels in the substance of the cervix, anteriorly with the same suture, and bringing down the nuttage in the posterior fornix. So this is, I've done almost around 30 cases till now, and the results are very promising for that in comparison to the laparoscopic approach for that. Now the rescue circlage is there again when there is a bulge, the membranes are bulged, and the rescue circlage by Foley's catheter, you just insunnate it, replace the membranes, and you find I've done almost, but 30% I've become successful. 70% out of this 50% usually ruptures during the time of examination. Or after 1 week, within 1 week, they get present with the leaking for that because of the infection. But at least 30% you get a very rewarding result of this particular thing with the technique of introducing this Foley's catheter and replacing it, and find the good length of the cervix. And then after the suture, you remove this Foley's catheter and get a good length of the cervix, and this is done. Infections, torch, say no to torch. It's a myth rather than the reality. And endocrine. Endocrine, apart from other androgen excess, hyperprolactinemia, diabetes mellitus, and other metabolic disorders. Main attention is given for the last 1 to 2 years on progesterone. Any pregnancy, progesterone. So use, abuse and misuse of progesterone is being there for that. I won't want to confuse you. By this time, you must be loaded with progesterone, starting from the pregnancy, beginning of UPT positive, till the end in the labor also it produces. Even you give your own partner one progesterone along with that, the pharma people will be very happy for that. So progesterone reproduction, I won't want to tell details about it, but this is a steroid nucleus, which is a 27 carbon atom compound clipped to 21 carbon atom compound, all progestrogens, 19 carbon atom compound, all androgens, and 18 carbon atom compound, all estrogens for that also. It's a mother hormone, but the history and nomenclature is very, very interesting. George Corner was the first in 1928 who isolated from corporal lutea of sows and named it progestin. 6 years after, the more political group, very highly political group, European group, Botner and Skimmed, isolated the same thing. But they didn't agree with George Corner, and they gave a different name, luteosterone. Sir Henry Dell wanted to compromise and a happy marriage between these two controversial groups, and it took 1 year. In Second International Conference on Standardization of Sex Hormones in London in 1935, he suggested bring progest from Corner and bring sterone from the European group and make it progesterone for that. And since 1935, the matter is solved. We are using the term progesterone, progesterone, progesterone. And these two, I must imply, there are 6 groups of progesterone, out of which in pregnancy, we want progesterone, 6-dehydroerythroprogesterone, dihydrogesterone, and 17-alpha-hydroxyprogesterone. 17-alpha-hydroxyprogesterone is well a quiescent effect. That's why it cannot be used in first trimester pregnancy. But mainly with the micronized progesterone and dihydrogesterone, there is a lot of debate of use of that. One says that is superior, one says that is inferior. But lot of trials, the PRISM trial, PREMIS trial, and the Lotus 1 and 2 has really solved some of the issues for that. Although there are some different subtypes which is required for that, all RPL do not require a progesterone. That is very important for that. Now the main thing which is used in first trimester, what is a progesterone? Progesterone is any agent which is converting from proliferative to secretory changes. And in endometrium there are stroma and the gland. The stromoglandular synchronization is done with 2 progesterone. One is dihydrogesterone, another is micronized progesterone. The rest of the progesterone doesn't cause stromoglandular synchronization. So we select a progesterone which is used in reproduction, particularly when stromoglandular synchrony is required for that also. So this is, you ask yourself, does all pregnancy require progesterone supplementation? And for whose interest is progesterone supplementation necessary? Whether the patient or the pharma or the physician. It is the need of the patient rather than the mood of the obstetrician. That is a priority for that also. And find out the rational use of progesterone in reproduction, infertility, LPD, LPS, all of you are experts in that. Threatened miscarriage, recurrent pregnancy loss, subchorionic hematoma, post preterm labor for that. So these are all which is known to you in following IVF, following IUI, progesterone supplementation is there for that. I don't want to go into the details of the controversial aspect of this regarding the trial. But this trial is very promising. It has solved the controversies and bringing out a controversy, create a consensus out of it also. A class of doctrines is not a disaster. It is an opportunity for all of us to find out and have a rational treatment modality for that. But even with that, even we are man of science, and I'm a strong believer of destiny and a strong practitioner of medicine. And even with that, we lose hope. And this is a goddess. I think Apurva must be knowing that. Those are coming from Tamil Nadu. There is a place close to Trichy. There is a temple called Sri Garvaraksha Ambigai. And lakhs of people go there. Only people who have infertility or a pregnancy loss. So this is specialized. Her portfolio is on pregnancy loss for that. So even God has a cabinet, the Prime Minister has distributed different cabinet minister, the Minister of Finance is Lakshmi, the Minister of Energy is Kali, the Minister of Health, somebody else. But this is out of which one particular segment is given to them. And this goddess is given a segment. You only deal with recurrent pregnancy loss. And lakhs of people failed with us and they go there, and maybe that the strong belief can make them success for that. Thank you very much, all of you and ladies and gentlemen.